Welcome again to the day. Today is on Tuesday. Yesterday we had another topic. Today we have a topic on psychosis. Everybody has been asking about the topic on psychosis. It's a very long topic. I know it will have some 3, 4 sessions, and we will know how to deal with each session. Psychosis is a very big problem, and at times you ever call a friend a psychotic one, you should think about it because it's a big topic and it entails so many things. When we talk about psychosis in mental health, generally people think of mad people, but let's see if really is psychosis of mad people alone, because whenever you call someone a psychotic person, you think it's hope I'm audible and everyone is listening, and everyone is listening to what I'm saying. Okay. Let's continue. Okay, I see in the platform, Karen White in the platform, and see Lady Anne was the first one. Okay, good. Hope everyone had a nice weekend and starting the week was okay. Mm, yes. Now, psychotic, as we say, these are group of mental health condition characterized by an impaired relationship with reality. You see, uh, uh, it's a group of mental health condition. Dorothy, you are making noise for me. Nini nachukua voice yako. Uh, Psychotic are groups are disorders mentally of mental health condition, characterized by impaired relationship with reality. You are in your own world. You see, this is why we call some people psychotic when they are really not psychotic. Now we go deep. We see what type of psychosis, what are the characteristics of psychosis, because we will see even several types of psychosis that come in. Now, the first hallmark, when you really want to know that this person is having characters representing psychosis, we'll see there is delusions. The first hallmark is delusions, being delusional. And then we have the second hallmark, which is hallucinations. And these people may have disorganized thinking, abnormal motor behavior. You remember us talking about catatonia and negative symptoms like apathy or lack of emotions. You see, sometimes people with psychosis may lack apathy and lack of emotions. You get it? Okay. Now, someone has asked what is catatonia. Let's see what is catatonia. Let's see what is catatonia. Yeah, catatonia. We see what is it. When we talk about catatonia, we're talking about a group of neuropsychic syndrome characterized by by variety of motor behavior and effective abnormalities. Affective, the ones that affect you. It occurs in the context of psychiatric disorder, especially mood disorder and schizophrenia. We talked about schizophrenia. I'm not going to repeat about that. Or due to medical or neurological conditions. You see, when someone has catatonia, I'm just explaining one of the symptoms of motor behavior when it comes to psychotic, so that we can understand and not be in the bushes when we are explaining some things like this. Now, catatonia symptoms may be stupor, no motor function activity, catalepsy, passive induction of posture, waxy flexibility, slight, even resistant to position by the examiner at times. You try to examine a person, it feels like he's a sticky wax. Mutism, little or no verbal response, not due to aphasia. Negativism, opposition or no response to instructions or stimuli. We have seen some people behaving like this. Postural, mannerism, stereotyping, repeating. You see, when it comes to stereotyping, you repeat the same thing after some time. And then the last one will be these people are always agitated. You see, all these are symptoms of catatonia when it comes, and you see, catatonia is one of the symptoms when it comes to psychosis. But you see, it has key features. These key features are 12 features. Mm? Posture, mannerism, stereotype, agitation, grievance, echolalia, echophrexia. You understand all these. Stupor, catalepsy, waxy flexibility, mutism. We all talked about these somewhere, previous topics. Now, there are types of catatonia. I'm going through catatonia so that we can understand what we are talking about. Because when it comes to psychosis, psychosis is not just one term named as psychosis. It is a character of mental health issues. We're just saying, or we are just explaining what psychosis is, and catatonia was one of the symptoms, and it is characterized by retarded catatonia, classic form, stupor, mutism, waxy flexibility, negativism, and posture. How you sit, how you present yourself in front of the social background and people. Excited catatonia, that is the second one. Excessive, purposeless motor activity, echolia. See, and then there is the third one, malignant catatonia, life-threatening, fever, autonomic, instability, delirium, and rigidity. Now, uh, let's go back to our topic, which is psychosis. And we have said, I'll repeat about psychosis. Psychosis are mental health condition characterized by impaired relationship between you and the reality, by a relationship within the person and the reality. The hallmark symptom includes delusional, hallucinations, disorganized thinking. You know what I'm talking about when I'm talking about disorganized thinking. Abnormal motor behavior. That's what I was explaining about catatonia, and I've seen there are three types of catatonia, and negative symptoms like apathy or lack of emotions. Yes, apathy and lack of emotions. Some people lack emotions when they have brain damage, or they are, you see, when you're talking about psychosis and mental health, you're talking about issues that are related to mental health. So the main types of psychosis we know, there are several types of psychosis, and the several types of psychosis that we know, I'll point them down so that we start one by one. Because if we don't characterize them and grade them, we will not know how to manage them. Most of these cases are being managed, not treated. They are long term and chronic. Mm. So, what type of these problems do you know? The first one that we already learned, we will not go down so much into it, is schizophrenia, and then there is the second one, which is schizophreniform disorder. Those are different things. Schizophrenia and schizophreniform are different things. Then we have brief psychotic disorder, and then we have psychoaffective disorder. We have delusional disorder. Sorry, we have delusional disorder. If you're taking notes, I'll go slow. I repeat, we have substance medication induced disorder. Those people that take alcohol and then they behave like people that are psychic. Mm. Most of the drugs, such as, let me say, marijuana, they present a person like a person who is psychic. We will see how motor functions relate to this psychic disorder. Let's go to psychic disorder due to another medical condition. We have like seven types of these problems, and we should look at them. Just a minute, I take this down. There's a question from someone, a question from one of you asking me. Let's see. Yes. Yeah. Now we are we are going back to talk about schizophrenia. You should ask yourself if you're talking about schizophrenia, every time we're talking about mental health and you're calling someone, this person is psych. Are you really supposed to call someone psych? See, these are mental issues that should be managed. Mm. The questions raise them in the platform, the normal platform that we usually raise questions because of faster seeing. And I usually say your question may help someone. Don't stay with that question because it may be burning to someone else. This one is. So if you stay without asking question, it's a problem because Mhm. Okay, 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 okay. Count. I can see Lady M, the platform. Karen White, welcome, welcome. Okay, just a minute. It's getting somewhere. Arranging a question so that we may not have several complications. Yeah, okay. Okay, okay, good. Let's see this one. 64. Okay. Yes, yeah, done. Back to the platform now. Now, we have talked about several ones. We are going to categorize. I think this topic will not end today because we have so many uh, issues to cope under psychosis. Because I'm seeing here we have 7 topics and we have to go down to the pathophysiology of psychosis. Now, we have given a definition of psychosis, definition of psychosis, which is mental health conditions characterized by an impaired relationship with reality. The hallmark symptoms we have named them delusions, hallucinations, disorganized thinking, abnormal motor behavior. We have talked about catatonia and negative symptoms like apathy or lack of emotion. So the 7 types of psychosis is psychotic disorder. We have started by schizophrenia, schizophreniform disorder, grief psychotic disorder, schizoaffective disorder, take note of that, delusional disorder, substance medication induced psychotic disorder, and then we have gone to psychotic disorder due to another mental condition. Yes, some medical condition or mental conditions may make a person to be psychotic. Now, what brings a person to be psychotic or behave in a manner that these people may be like a psych person? There are several things that are pathophysiology to this. Now, one of it is dopamine hypothesis. We have really talked about dopamine, which is a neurotransmitter of the brain at the mid brain. Mm? Serotonin was at the frontal brain, and now dopamine that gives you remember it's a pleasure neurotransmitter. Though exactly is not fully understood, several mechanisms are implied. So these are hypotheses. So when you are doing this, when you study hard, you do your PhDs and doctorate degrees, or you may want to do, for those that are in the medical field, you may want to research on this. You take the levels of dopamine, do IQ tests for several people so that you prove to us that this is the essence of psychosis. Now, let's go to dopamine hypothesis. Dopamine hypothesis here, you see, hyperactive. You know what I mean when I'm saying hypothesis, not fully understood, but under research. Hyperactive of dopamine in the mesolimbic pathway causing positive symptoms. When you have high neurotransmitter called dopamine, and then it causes some symptoms, positive ones, because the higher a neurotransmitter goes, it will come back with a negative feedback or a positive feedback. So this one comes up with a positive feedback, and the positive feedback is hallucinations. The brain will start giving you some hallucinations or giving you some reality checks that are not real. You are looking at things that are happening that are not real. This happens when some people are acutely intoxicated with some chemicals or sometimes even electrolytes. Because when you have a problem with the kidney, electrolytes may be impaired. When creatinine goes up, you see what happens is you may start having the delusions because of impaired neurotransmitters in your brain. Or sometimes when you have ketoacidosis secondary to diabetes, you may start having the delusions. Why? Because it is impairing the neurotransmitter release and reuptake. You get it? Now we continue. Hypoactivity in the cortical pathway. We have the mesolimbic pathway, which reuptakes dopamine, which releases dopamine. But we have the mesocortical pathway. Mesocortical pathway may lead to negative symptoms. You get it? Hypoactivity, lack of emotions, poor motivations. Now relate this to our first the topic when we talked about these neurotransmitters. We talked about dopamine as a pleasure hormone. Mhm. And you see here, we're being told that at this hypothesis, you from we call it our Bible of Psych and Health Matters, the DSM-5. This was seen that hypoactivity in the mesocortical pathway may lead to negative symptoms, a lack of emotions, poor motivation, because now the dopamine has gone down. And you see, some drugs may inhibit the release of this. Now, that one was the first hypothesis. We go to the second hypothesis, which is glutamate hypothesis. What do we mean when we call glutamate hypothesis? Receptor hypofunction. Glutamate deregulation may contribute to positive and negative symptoms. Someone is asking functions of glutamate. Okay, let's continue first. Okay, supported by PCP and ketamine, induced psychosis. CPC, ketamine induces hallucinations. That's why when you take people to theater and you give them ketamine, they wake up uh, like a person who is psychotic. In the unit called yeah, uh, there is a unit we call please acha kupiga kelele tafadhali. Turn down your phone, please. Joy, yes, please turn down your phone. The Nini is picking your. Okay, now we continue. Sorry for that. Uh, we talk about anesthesia, and we talk about something called joy. Joy, yes. I mean, please turn down your phone. I mean, please. There is a unit called there's a unit called anesthesia, where we learn about ketamine and its effects. So when we talk about ketamine and its effect, these are effects that come along after you've been induced. So you see, ketamine, is one of them. Ketamine is one of them, and it induces the psychotic issues, say hallucinations. So we talk about not catatonia. Someone was asking something here. Glutamate, functions of glutamate. Glutamate hypothesis is one of the symptoms that are presented when it comes to glutamate functions. This is a neurotransmitter in your brain. Fun- This is a neurotransmitter in your brain. It's the main excitatory neurotransmitter. It's the central nervous system. Hmm? It plays a critical role in normal brain function but can also contribute to neurotoxicity and effectively activated. You see, no, it's excitatory neurotransmitter. Excitatory means it excites some other functions in your brain or other things, even some enzymes. Glutamate is responsible for fast excitatory signals in the CNS. But you see, here we have the hypothesis, glutamate hypothesis. So it can excite positive or negative symptoms supported by PCP and ketamine. So when you give a lot of PCP or you inject someone with ketamine, it may excite. So the people that like using ketamine when they feel they have pain, it may induce hallucinations. And this one is a real problem because the more you use it, the more suppression of the brain function. Here, you see, as we talk. Now, we talk about the third one, the serotonin dysfunction. We talked about serotonin, altered 5-H2O receptor activity. Serotonin is released from your brain, frontal lobe of your brain, has been linked to, especially in typical antipsychotic drug response. So H2A in the frontal lobe of your brain, what is H2A receptor activity? Which is linked to serotonin, the neurotransmitter called serotonin. You see, we're starting from the frontal lobe of your brain as we go back. The 5-H2A receptor is a subtype of serotonin, 5-hydroxypyramide or 5-HT receptor, primarily found in the nervous system and peripheral tissues. It plays a crucial role in modulating mood, cognition, perception, and various psychologic process. You see, and various psychologic process. Now, you really understand about these matters of neurotransmitters. The excitatory part is the one which makes someone to be delusional or starts to hallucinate. We have seen about glutamate. Now, this is serotonin. Modulating mood, cognition, perception, and various psychological process. 5-H2A receptor basics, G protein coupled receptor. You see, it's a let me see here, G receptor, G protein coupled to G protein. Now let's not go down to the chemistry. We will go down to the chemistry when time comes, when we will be talking about specific issues. Now we have the fourth one, brain structural abnormalities. Brain structural abnormalities like enlarged ventricles of the brain that are enlarged. You see, they can be big and have a hyperfunction, or can be big or have a hyperfunction, release more neurotransmitters, or they can be small and release low neurotransmitters. And you've seen how serotonin and glutamate, which is an excitatory neurotransmitter is related. Yeah, neurodevelopment and genetic factors, insults, prenatal insults. You see, when the mothers go to deliver, and then infection comes in because of not handling the fetus well. It's very important when you go to a maternity, you're the one who is handling it, to take care of the fetus how it is needed. You get it? Hypoxia, lack of oxygen in the brain, causing some disturbance in the normal function of your brain at an early stage. It may lead the problem may lead to reduced neurotransmitters. Now, most of these psychotic issues that we are seeing, the pathophysiology, because we have not finished, we are seeing most of them are linked to neurotransmitters regulation and dysregulation. So, as we talk about psychosis, when you talk about a person being psychotic, you should check on mostly hyperfunction or associated uh, syndromes. Hmm? We have syndromes like the Turner syndrome. We have syndromes like the hmm? You have syndromes, or the people that are born with these syndromes. They may exhibit some things that you may see and you feel that this person is not well. It's because maybe the brain is small and it is exhibiting some problems that may show us the complication of psychosis. And you see, sometimes when you someone is calling, okay, it's important to check out and see the problems when they come. If a person has a syndrome like Turner syndrome, you see it has problems when it comes to sex chromosomes. Mm? Klinefelter syndrome. Mm? This one always affects the male due to extra X chromosomes. You get it? But it may bring up complication when it comes to neurotransmitter induction or release from the brain. You get it? We have triple X syndrome in female, chirotype syndrome. This is when you have triple X plus 47 uh, others that are being produced when the gametes are exchanging. You see, these are problems that may even be inducing some problems in release of neurotransmitters. Yes, there are so many like androgenic insensitive syndrome, mm, Klinefelter, which is very common. You see, let's continue on the next one, which is neurodevelopment and genetic factors. These are when it comes to prenatal insults, a strong genetic predisposition, like disc formation, gene mutation, inflammation and immune dysfunction. You get it? Elevated cytokines and autoimmune associations. You see how they relate. Hmm? There is key involvement with the mesolimbic pathway, mesocortical pathway, which is the pathway that regulates glutamate, yeah, and nigroristal pathway affected by antipsychotic. You see, tubular infusidibular pathway. Those are the pathways that are affected, and then someone starts to start to be psychotic. Now we start with the first one. This one I'll go to it faster because we had discussed it in deeper, which is schizophrenia. We had a topic previously about schizophrenia and we discussed it deeply. We can go through the here and see how we can help these people. But I think the case of management of this will not come now. They'll come because it's a wide topic. We are dealing with types and definitions of it. and pathophysiology. Mm? Now, what is schizophrenia? It's a chronic psychotic disorder characterized by disturbance in thoughts, perception, emotions, and behavior, delusion, hallucination, and disorganized speech and behavior. Mm? Disturbance in thought, perception, emotions, and behavior. And then we have delusions, hallucinations, and disorganized speech behavior associated with significant social and occupational dysfunction. Causes: genetics, neurochemical, brain function, prenatal traumas. That one we have talked about, like infections, birth, and malfunctions. Environmental, childhood trauma, stress, and we've talked about how stress can come out the injury of your brain and urban upbringing. Pathophysiology, when it comes to this schizophrenia, we had talked about schizophrenia. Please go through those notes. Here we have mesolimbic pathway. This one always increases dopamine, positive symptoms like hallucinations. When we talk about positive symptoms, always think about hallucinations. And then we have mesocortical pathway in the brain. How when I'm talking about the pathway, this is how signals are transmitted in the brain through the the what we call the neurotransmitters, how they pick up, how they release. You see how they affect the other part that is receiving. This is what we call the pathway. But you see, we have mesolimbic, we have mesocortical, we have nigrostriatal, and tubuloinfibular pathways. So mesocortical, this is the opposite of mesolimbic. When dopamine comes down and there is negative cognitive symptoms. We have seen positive, it comes with delusions. But when we talk about negative, this is on the mesocortical pathway. We talk about a person who is withdrawn from society, doesn't want to talk. You see, mm, this is the negative pathway, which is mesocortical. Then we have nigrostriatal pathway affected by antipsychotics, extrapyramidal symptoms. What do we mean? Very important. How do you define extrapyramidal problems? You see, extrapyramidal. What do we say about extrapyramidal symptoms in schizophrenia or any other? What do we call this? Because sometimes people confuse extrapyramidal complications with symptoms that they are supposed to be treating, hmm, or the disease that these people are supposed to be treated with. So extrapyramidal symptoms, what are these? Are drugs-induced movement disorders that are mostly associated with antipsychotic medication, especially first-generation antipsychotic like haloperidol. You have ever given someone haloperidol and you see uh, there is some funny movement with the head, the hand, or the legs. These are symptoms due to dopamine D2 receptor blockage and the nigrostriatal pathway of the brain, which affect motor control. You see, and there we come with this term called dystonia. Dystonia, movement. Someone is not aware, but you'll see the head is just moving. The head is dystonic movement. A time onset, hour, days, starting increasing dose of antipsychotic. You see, akathisia, akathisia. These are things that are associated with the problem. Parkinson's drugs, drug-induced Parkinsonism. So the drugs you give for antipsychotics may be the problem at times for some movements. Tentative dyskinesia, TD, we call it TD, tentative dyskinesia, causes typical antipsychotic. You are treating psychosis, and then the same drugs are bringing psychosis. Just imagine you are treating someone a problem and you are increasing the problem. Hey, Steve in the house. Welcome, Steve. We are talking about psychosis and we have given the types of psychosis, and we have defined what psychosis is. So the first one that we are talking about is schizophrenia. And we have seen how at times schizophrenia brings extrapyramidal problems. It may bring, we have talked about the problem that comes in when it is affecting the brain, the pathways that we have talked about: mesolimbic, mesocortical, nigrostriatal, and trigerofibular. So when you give someone some drugs, you give someone a drug, and then you see some problems are coming out. Don't always say this person is coming, is not improving. Think about the drugs that you've given. So if you have someone who is psychotic, and then you give someone, you give haloperidol, and then you see issues like akinesia and dystonia, you think about withdrawing the drug. First generation drugs, of course, they come with this, and in giving other drugs that may help. Okay, we have tuberofibula antipsychotic induced prolactin. You see, tuberoinfibula, for those with heavy tongues. eh, antipsychotic induced prolactin increases, and then you start having delusions, hallucinations, disorganized speech, disorganized catatonic behavior, negative symptoms like flat affect, reduced emotions, anhedonia, inability to experience inability to experience pleasure because the reduce of dopamine, there is reduction in dopamine production, avoliation, lack of motivation. You're just there. You are not motivated with anything. You see, and then you may have some problems like cognitive symptoms, impaired work memory, attention, and execution function. Sometimes you do something and you become forgetful. When you become forgetful, you know this person is suffering from cognitive measures functions, and these cognitive functions maybe have attention, you get, and sometimes you fail to execute what you really know. Mm. So how do you know someone has has schizophrenia? You will know someone has schizophrenia in this way: one, delusions; two, hallucinations; three, disorganized speech; four, gross disorganized or catatonic behavior. We have talked about catatonia. And five, negative symptoms. The negative symptoms we have talked about: flattened affect, alogia, anhedonia, avoliation. You get it? Now, cognitive issues is impaired memory, attention, and execution function. Now, we see disorganized speech. This is negative symptoms, right? No, these are positive ones. Gross, disorganized, and catatonic behavior. We have negative symptoms too, hallucinations. Now, we go on. Sometimes we have in investigations like the complete blood count, electrolytes, liver function tests. You may do these tests, and sometimes urine drug tests to see if someone has been on a substance. Neuroimaging to see if the brain is okay or is being damaged, or EGG to see if the person we are talking about has a problem when it comes to. Now, we have talked about, see, this is whatever we are talking about is schizophrenia. I'm not going to talk about the drugs of schizophrenia because we talked about them when we were talking about schizophrenic disorders. Now we continue on subtypes of schizophrenia, and some subtypes here, like paranoid types. We have disorganized. We have disorganized type. Mhm. We continue. We have disorganized types. We got catatonic types. We have residual types and differential types. Now, what are disorganized ones? These are speech behavior disorganized flutters and inappropriate affect. Catatonic type are motor inability, waxy flexibility, and mutism. That one we have talked about. Residual types like no prominent positive symptom, mainly negative ones. You are always having negative symptoms. And differentiated types, mixed symptoms, not fitting above types. You are always having positive and negative symptoms. When I'm saying positive and negative symptoms, we are talking about at times you have hallucination and then you come and have speech disorganized behavior, speech and behavior disorganization. You see, those are positive and negative types, and this is how you may differentiate when it comes to psychotic behaviors. You get it? Hmm? Now, there are some differential diagnosis, some things that you may confuse for a person who has psychosis, like bipolar with psychosis. Brief psychotic or disorder. This may be caused by a substance like marijuana. Delusional disorders. You see, some people, when they are introduced to substance, they may exhibit psychotic disorders. And then we have some substances like cocaine, hmm, that may induce increase in dopamine and flatter you. You become so excited, and the next time you are so down. You see, those are substances. This is, we're talking about the first type of psychosis, which is schizophrenia. We have talked about schizophrenia at a wider spect at one of our topics. Please go and read about it and see it deeper. You will understand plus management. And then we have schizophreniform. Schizophreniform. You remember us talking about schizophreniform. These are types of psychosis, this psychotic disorder. Hmm? What is the difference now between schizophrenia and schizophreniform? We talked about it. Everyone knows about these two differences. Certainly, uh, what is the difference? But now let's know what is schizophreniform. It's a short-term psychotic disorder that has the same symptoms as schizophrenia, positive and negative uh, uh, symptoms. Hallucination, disillusion, memory, cognitive impairment, all of them short term. It may last up to less than 6 months, may progress to schizophrenia, because schizophrenia is a chronic issue and it goes to months or years. Genetic predisposition is a risk factor. If you have someone in your family that has this problem, please don't use substance. Biological, similar neurotransmitters dysfunction as schizophrenia. When dopamine is increased, you will find this person doing what? Having this problem. Hmm? We have environmental triggers like stress, trauma, and substance. Hmm? You see, these are things that you should look at, and you check to find out if a minute. Now we will continue and address, because yes, I mean these are utamuexamine nani, and then you write notes. I will not see him. I want to finish schizophrenia to take up, and information. Okay, we examine him. Kadara has gone. Yes, examine him. Take bronchial sounds. Check BP, pulse rate. All those give upon the difference between that time, because now he's not getting any medication. Write for me down, I'll check them later. So I want to finish this. Okay. Okay, we continue on the genetic predispositions. Genetic predispositions are Risk factors. Biological, similar neurotransmitters dysfunction as schizophrenia, rise in dopamine. Environmental triggers, stress, trauma, substance use, neurodevelopment abnormalities. Mm, You see, at least two of the following for a significant portion of time during 1 month, least for 1, 2, or 3 months. This one, like delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms, flat affect, alogia, and avoliation. We have talked about those three or those four words. Duration, it may be 1 month or less, but at least less than 6 months. Get it? Schizoaffective disorder and mood disorganized must be ruled out, not due to substances or a medical condition. Make sure that this person that you are examining or treating has no problem with substance abuse so that you may rule out this is schizoaffective disorder. Hmm? Okay? Now, you will need to ask even about any drug that this person has been given, because you have seen that most of the people when they show symptoms of psychosis, they are given first line drugs and injections, and they may exhibit extrapyramidal symptoms. So when you are receiving this client or a patient, please check at this patient and rule out any other drug. Drug history, you know how to you check all those. For those that are medical professionals. Now those ones, the two of which I've covered, those ones I'm not going in any detail because we have gone in details on schizophrenia, and now everyone is perfect, is a professional on schizophrenia. Now there is this one called brief psychotic disorder. Brief psychotic disorder. Hmm? At least for when we talk about brief, we talk about a time period. So what is the time period of brief psychotic disorder? Hmm? Mhm. For at least a month. For at least a month, that one can be brief, but sometimes it may be intermittent. It can come for a week, it stops, then it goes for another week, it stops. So you should check, is it substance induced or what? You get it? The definition always is brief. The psychotic disorder is a substance of psychotic symptoms, a sudden onset of psychotic symptoms, such as delusions, hallucinations, or disorganized speech or behavior that lasts for more than 1 day but less than 1 month. Can go up to 24 hours because that is 1 day, but less than 1 month. Yes, like 3 weeks or 2 weeks. That one is brief psychotic disorder. Has a full return to premorbid function. You, the person goes on to return to fully function and well mentally, often triggered by a stress or trauma. There's the people that work in factory, you hit your head somewhere, get an accident, and then after some time you start showing exhibiting psychotic behaviors. We'll call it brief psychotic disorder. You see, psychosis is psychosis because of neurotransmitters, but it is categorized by the clinical manifestation and medical manifestation. Those are the ones that guide us to know which neurotransmitters we are looking at and which neurotransmitters we should check at. Like if you are exhibiting positive symptom, we talk about dopamine. Mostly, when you are exhibiting negative, we talk about serotonin. Now, presence of at least two of these will show us that this person may be undergoing some problems, and it may be brief psychotic uh, uh, condition like delusion, hallucination, disorganized speech, grossly disorganized or catatonic behaviors. At least one, two, or three of these. But you see, some people may present with both of them. Hmm? And then we have the second one, which is duration. And duration, we have said it can be 1 day but less than 1 month. Eh? Not better explained by a person who is not on drugs of schizophrenia, schizoaffective disorder, mood disorder with psychotic features, substance use, or general medication. There are some medication that may use and then they interfere with dopamine release. You see, this may show us that this person is undergoing what? Positive or negative. You see, subtypes of this with marked stressors, brief reactive psychosis. Yes, there are subtypes categorized into three. mm, Workout marked stressors, no clear cause. And then we have with postpartum onset, postpartum psychosis in women who have just given birth. Yeah? You have always talked about postpartum psychosis induced or within 4 weeks of postpartum. After delivery, a woman, after 4 weeks, this woman starts to show signs of psychosis. Why? Because now the delivery process was so hard to this woman, and because it was so hard, what happened? Some neurotransmitters were destabilized, and this woman starts to present psychotic behaviors post delivery. That's why we call it post psychotic behavior delivery. Mm? See, but it is always cleared out after 4 weeks, because now the body regulates the dopamine and this woman becomes okay. Now we have seen those are the three subtypes. Mm? And there is stresses like hormonal changes, the causes, psychological stress, death of a loved one, trauma, abuse. You see, those are the things that may cause this. Genetic vulnerability, family history of schizophrenia or mood disorders. Substance related can mimic BPD, yes. Mm. Clinical features, onset, sudden. This is very sudden when it comes to onset. And then symptoms are like hallucination, delusions, obvious. These are symptoms of psychosis. Mood may be liable but not central to diagnosis. Yes, insight often impaired. Duration for 1 week or 1 day to less than 1 month. Recovery, full return to pre-morbid level functioning. You get it? Investigations, toxicology, CBC, neuroimaging, all those we do. But there are some things like treatment with antipsychotics, supportive care, and then there is long-term monitoring. You monitor these people as the problem progresses, and see, there are the people that should be seeing a specialist, psychiatrist, for at least 6 months after the 1 month, so that this psychiatrist can say this person is okay now. Because maybe there is something that is inducing the psychosis that this person, you may not know until you follow up. You follow up slowly and slowly. Yes, there is the other one, the fourth one. You see, there psychosis is not just a psychotic problem. There is the other one which is called schizoaffective disorder. Schizoaffective disorder. This is the fourth type of psychosis that we know. Schizoaffective disorder. What is schizoaffective disorder? Hmm? A mental illness that shares features of schizophrenia and mood disorders. We talked about mood disorders. So you have schizophrenia symptoms, but you are exhibiting some symptoms of mood disturbance. It is characterized by symptoms of delusions and hallucinations. These are related to psychosis or no, schizophrenia. And then, along with mood disorders, major depression or mania. We talked about depressive disorders. You remember about major depressive, which is the major one in depressive disorder or mania. You remember it? Yes, we continue. The psychotic persists for at least 2 weeks without mood and symptoms. You get it. It may progress for at least 2 months without moods and symptoms. So when we talk about schizoaffective disorder, you think about two things: symptoms of schizophrenia and mood disorder. So you may bring a word called mania into this. We talked about mania. Mania, you remember it in major depressive disorder. Now, there is a criteria that we use to check on and classify and diagnose these people, and it is A, B, C, and D. Yeah, two, three. Now, there are four. Now, an interrupted period of illness. You see, the illness has an interrupted pattern. There is a major mood episode, depressive or manic, concurrent within A, schizophrenia, for equal to two of these symptoms that I'm going to talk about. So when you have depression plus at least two of what I'm going to say, know that this is quite a diagnosis of this. Delusions, hallucination, disorganized speech, disorganized or catatonic behavior, negative symptoms. And then we have B, which is psychosis. Psychosis symptoms, the positive ones, delusions and hallucinations, must be present within 2 weeks or equal to 2 weeks in absence of any mood or during the illness. Hmm? You see that? We have said the first one, you have manic or depression, major depressive disorder, and with the criterion of A, schizophrenia, delusions, hallucination, disorganized speech, disorganized or catatonic behavior, or negative symptoms. Now, there is psychotic symptom, maybe 2 weeks or equal to 2 weeks. You get it? Hmm? And then we go to mood symptoms are present for a majority of the total time of. So when this person is exhibiting this symptom, the larger part of symptoms we should check on is the mood symptom. Major depressive disorder is the mood symptom. You get it? Not due to substance or general medication. Maybe you have not this. If you find out any drug that this person was given previously, it was not linked to any first line antipsychotic drugs like haloperidol. So you will know this person is suffering schizoaffective disorder, because now depression affected by schizoaffective. You see, schizophrenia is a psychotic issue, so it is affected by another thing which is coming in as a mood or mania. That's how you know this one is having schizoaffective disorder. Hmm? And you have ruled out all the drugs. Maybe this person was just given a paracetamol, brufen, but not antipsychotic drug or any other drug that may cause toxicity. Toxicity of major organs may cause psychotic symptoms. Mostly toxicity of organs like the kidney and toxicity of the organs, even liver organ. Because if bilirubin rises up in kids, you usually see we get kernicterus in the brain. Kernicterus may cause this, and you see it's a life-threatening process that causes even encephalopathy. Encephalopathy is psychic symptoms after bilirubin has hit some parts of your brain. Hmm? And encephalopathy, brain encephalopathy. And then we have the urea and electrolyte imbalance, electrolytes. Your kidney is injured because of alcohol. I usually say people to stop taking alcohol. Because now, when your kidney is injured because of alcohol or some substance, what happens is creatinine rises up, and when creatinine rises up, what comes in? High blood pressure, brain dysfunction, all those you see. So some substances may relate for you too, but you need in schizoaffective, you rule out there is no whatever that I've said about substance. There is none of that. Key distinctions from related disorder. You see, in there are some things we have talked about like major depressive disorder, bipolar disorders and psychosis, schizophrenia, schizoaffective. So symptoms without mood of symptoms and mood symptoms prominent. You can write a table down and write psychotic symptoms without mood symptoms. And the other one you write mood without symptoms. This one will really help you to rule out. Yes, Michael N. Hi, welcome aboard. We are talking about psychosis, and we have seen several types of psychosis. Psychosis, uh, you understand when I'm talking about psychosis, we're saying a person has gone nuts. Now we want to know which type of nuts a person has gone. Now, in schizoaffective psychosis, at least 2 weeks, hmm, or equal to 2 weeks. And then there is major part of symptom. You are depressed and you have psychotic issues. Hmm? Schizophrenia. Schizophrenia. Yes, it's there. But when you check at the mood, is it prominent? No. Schizophrenia does not have depressive disorders. So in schizoaffective, it has depressive disorders and psychotic symptoms. And then bipolar. Bipolar, does it have psychotic symptoms like hallucinations, delusions? No, bipolar does not have that. But bipolar has mood symptoms, depressive states, and depression is in bipolar. So, major depression and psychosis, we will have psychotic issues if it is only in depression. And then we will go to mood symptoms if prominent. Yes, you get it. Now we go down and check on types of schizoaffective disorders. Bipolar type includes manic episodes with or without depressive disorder. We have depressive type, only major depressive episode. Depressive type, only major depressive episode. Causes of this one, we may see genetic causes, neurochemical causes, brain structure, environmental. You see, environmental like stress, traumas, and substance abuse. Substance. Why are we talking about substance always? I wish people will stop using toxic substances because every part we're talking about toxic substances. We have here something called psychotic features, clinical features like delusions, hallucinations, disorganized speech or behavior, negative symptoms. Now, someone asked about differentiating between mood disorders and psychotic features. Now, these are the delusions, often paranoid, hallucination, typical and auditory. Hmm? You talk about what you are seeing. Disorganized speech or behavior. You are not talking. Maybe this person is really talking incoherent words that you may not understand, but you may understand like one, two, three words, so that you may know this is a disorganized speech. Negative symptoms in psychotic features, we talked about them like flat, affect, and avolition. Now, these are the clinical features, medical features in psychosis: delusions, hallucinations, disorganized speech or behavior, negative symptoms. You get it? And then we have mood features, depressive episode like sadness, guilty, fatigue, sleep disturbance, uh, and appetite. Sometimes you just don't have appetite. you will know this one is a mood feature. Manic episode like euphoria, irritability, increased energy and impulse. Mm, Manic episodes. You see, we are still talking about manic episodes. Investigations, we have so many investigations. We have talked about endoderm damage. So when you think about investigation, think about UECs, liver function tests, thyroid function. Those are the end product. Urine tests, because it is the product from the, yes, urinalysis, the normal one. Find out the protein in the urine, pH of the urine, yeah, bilirubin. Check if there is bilirubin, because you have seen bilirubin can cause encephalopathy in the brain because of kernicterus. So you check all these things. You don't stop checking because you may misdiagnose the patient. Listen to that. For health workers that don't are in a hurry, in you that you are listening to me, you are in a hurry to write medications and you have not given enough evidence for your diagnosis. That is not correct. Always rule out everything. Come down to a diagnosis, not an impression. Because now you will give first line drugs like haloperidol and you will make this person to exhibit more symptoms. Never mismanage a patient. Better you do all the tests so that you can come down to a better to a better diagnosis instead of hurting a person. And you know, the more you give more drugs with the wrong diagnosis, the more you are forming this person to be resistant and to produce more positive symptoms. You've seen. So we continue. This is matters concerning the brain. Hmm? Very complicated. So pharmacotherapy, mostly we can give antipsychotics, mood stabilizers, antidepressants. Combination therapy is very important. Antidepressants, you remember, serotonin reuptakes. Mood stabilizers like lithium valproate and carbamazepine. Hmm? Core treatment for psychosis, mostly antipsychotics, risperidone, olanzapine, paliperidone. Now, if you give someone, this is very important and I want you to listen. If you give someone an antipsychotic and this person has a mood disturbance condition, you are worsening the problem. And that's why I'm hard on this. Differentiate between mood disturbance and psychosis. Because if you give a person who has bipolar or olanzapine and this person is not exhibiting any problem concerning psychosis, that person will start exhibiting psychotic issues. Why? Because you are bringing down the uptake of neurotransmitters like dopamine, serotonin, and glutamate. Remember, there is the other one called norepinephrine. So be very careful when you are choosing a drug to give these patients. You can be a doctor or a health worker who is not who is bringing more problems to this patient by the drugs that you are prescribing to this patient. And you see, there is a drug called paliperidone. Is the only FDA approved drug specifically for schizoaffective drug, because paliperidone treats both mood and psychosis. You get it? So even if you are not a medic and you are listening to me, go through your symptoms. Although it should be so hard for you, this is left for the professionals. Psychosocial intervention is very important. Beauty in the platform. Welcome, Beauty. Today we are talking about psychosis. Psychosis, and we are in the second one, which is psychoaffective. Psychoaffective one. So if there are some people that exhibit some issues in the family, yes, yes, yes. Hi, hi, hi. I've seen you. Seen you. Yes, yes. It's a very big topic, and we are going so slow so that people may understand. You see, people confuse psychosis and mood disturbance disorders. So that's why I've said it's very clear here now. A person has come to you exhibiting these delusions, hallucinations, disorganized speech, negative symptoms like flutter and revolution. You will know that this person is psychotic. And then we go to mood disorders. There are some people who had mood issues, and then you say these people are psychotic, like people who are bipolar. Depressive episode like sadness, guilty, fatigue, appetite, sleep disturbance. Manic episode like you are always euphoric, you are always irritable, increased energy, you do things with impulse. You see, this one is not psychosis, this one is not schizophrenia, this one is mood issues. So you differentiate them so that you get the right drug. You see, now we will really like to go down to management, but generally, because I'm talking to a multitude of many people right now, I want you to know that psychoeducation is important for the society, because that person is living in the world of with other people. Cognitive behavior therapy is very important. Family therapy is very important. Social skills and training is important. And you should put this person to vocational rehabilitation, where there are specialists that know how to deal with these people, because they are human and they need to be helped. You see, when they are introduced to vocational training, there are some many things that go on around there. Don't just call people psychic and then you leave them. No, they should be helped to come back and do something in the society, in the social environment, to help other people. You see, so hospitalization may be needed in acute when you find that this person may be suicidal or some other dangers may come out. You see, it may you may need some hospitalization, and we go down to check delusional disorders. Yes, if anyone has a problem, don't just peep in and go. Please ask a question. Please share the video, and let's get to know. Let's get to learn, because we notice that these are things that we see. These are things that we will always see daily life, and when we see them day in daily life, we start judging some people negatively. But you see now, as we talk, we have learned that psychosis don't just come. A person just don't go nuts. There are some things that happen in the brain that they make this person to go nuts. Now there is the other one. We have gone from the fourth, the types of psychosis: schizophrenia, schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, which is including schizophrenia plus mood, and then now we have delusional disorder. Delusional disorder, which is the fifth one. Types of psychosis. People, you see now, you don't judge those people we call mad people. Don't judge them. At least right now we have started knowing that these mad people, there is a problem that is medical that should be sorted out. Some people say that someone has gone to juju, to a sangoma. I don't, yes, a sangoma. Someone has gone to a sangoma or is haunted. Those are not true. This is now true chemistry. This is science we are talking about. So when you see a mad person, there is nothing that someone went to a sangoma or juju or given or said that this person will be mad forever. It is not connected. Listen to this. Here is an explanation of delusional disorder. How is delusional disorder coming in? Delusional disorder is a psychic condition characterized by one, persistent and bizarre or bizarre delusions. You are always disillusioned, lasting for at least 1 month. Function is generally not impaired aside from delusional content. No other prominent psychotic symptoms. You're not exhibiting hallucinations. You are not exhibiting disorganized speech. You see, but there are so those things that will make you know This person is delusional and is exhibiting psychosis type 5 that we are talking about. What are these? A. One or more delusions lasting from at least 1 month. More than 1 month or at least 1 month. Schizophrenia has never met this. Criteria of schizophrenia have never been here. There is no prominent hallucination. There is no disorganized speech, catatonia. There is no funny movement or negative symptom. Function is not marked impaired. You see, and behavior is not absolutely bizarre or odd. Hmm? If mood episode occur, they are brief or someone asked, you just don't talk of words. We need to know what these words mean. Hmm? Like delusions. You see, they are so we talk about these words, but sometimes we don't really understand these words. It's very important to understand some specific words so that you may not be just random when talking about things. What are delusions? Are fixed false beliefs. Delusions are fixed false beliefs that are not in line with reality and are not corrected by logic or contra evidence. You see, they are a core symptom of psychotic delusions. A family held belief. You believe, false belief, despite clear or obvious evidence to contra. There is evidence that you are wrong, but you believe in that thing that you believe in. So mostly this happens in culture. The one that I've just said, someone becomes mad or psychotic, and then you say that if someone did not like that person, he went to a zangoma. He went to a zangoma, and now that woman, that man is walking out naked or is very dirty. My friend, there is no connection between African magic and science. There is no connection. There is no connection between African magic and science. It is this. The people called the Sangom or witches or those people, they are very clever and they know how to counteract issues. They know that that person in the brain, there is something that lacks. And then at times he may take this person, he may tell a person now, what you do is you do what? You give this person uh, you give this person this item like coffee. Be giving this person coffee or these leaves that I'm giving you. You cook, let this person drink. This person knows because for a long time it has been used. It brings down dopamine in the brain. So the person who is a Zangoma knows if he drinks these leaves, this person behaves like this. But the Nsangoma himself does not know how it works in the brain. So you take the leaves, you cook, you give your husband or your wife, the dopamine goes down, and when the dopamine goes down, what happens? You start behaving crazy. And then you say that is Agoma is a great person, he knows how to work out. Bullshit. This is pure chemistry. It is pure science. You this is pure science. And the people in the villages, they are so because they have lived for so long, they know how to play with people's mind, but they don't know the science. They don't understand the science in here. Sometimes when you are a health worker or you are a doctor and you look at some things, you will laugh or you will laugh in the wards or in the hospitals and hey, let me laugh today. This topic is awesome. I'm not laughing because people are being psychotic. No, I'm laughing on how people play with other people's mind. So when you're taking your child, you hear someone saying at home, that person went to be given this and that. My friend, just know it's a joke. Hmm? Just know you're being played in the mind. In our community, I come from a community called the Luyas, and there are so many myths there that at times I usually I'm usually being given by my uncles, my grandfather, and he and she was there. And you see, I laugh at them. Now that I'm a dog, I listen to them and I laugh. Now, let's continue. If we were at the criteria of knowing, the first one we said, uh, one or more delusions lasting for 1 month or less. A criteria of schizophrenia has not met this, because now we are dealing with delusional disorders. You are always holding on a false behavior. You are always holding on a false. You see, you are always thinking of a of a false behavior that is coming in, eh? And you are holding on it so that you may you get it. Now we go on. It's not due to substance use, medical condition, or antipsychotic disorder. You see, it's not due to all of this. Now we check on one, which is a romantic belief that someone is in love with them. These are types of things that you may think, and you feel that this person is just let a minute. Come out, I'll call you later. I'm in a very committed meeting. I'll call you. Yes. Okay. You see, you see, this is uh, uh, um, things that we should look at when we are talking about these delusions. When we are talking about these delusions, it's a romantic belief that someone is really in love. This person is just holding on that this person is in love with me. Hmm? And you see, the person that is this person is thinking is in love with does not even know this person. Hmm? Maybe he's a celebrity or so. People uh, love celebrities. Hmm? These are these are typical delusional psychotic issues. Eh? Aromatic, believing you are in love with a celebrity that you've never met, and you believe that celebrity is in love with you. Mostly in the middle age, it goes up to adulthood. You see, grandiose. We talked about grandiose belief of inflated worth, power, identity, or knowledge. Hmm? There are some people that you will meet, and this person will tell you how he was in the military, how he used to be in the military, how he used to plan things in the military, how he was a big person with ranks in the military. But if you follow up on the person, you will find that this person has never been around that area ever. It is in his or her head. Hmm? How this person was a big politician one day in life, and this person was having power and money. And you see, you look at the person and you see, by the way, this person is not. But the way this person is speaking with confidence, you may get into the trap of being lied on and say, for real, this person was, but it's not true. And then there is this, we are in the delusions of jealous and of delusions. The types, the subtypes. We have jealous. Believe that one partner is unfaithful. You remember we talked about these things. We talked about these things when one believes that the other partner is jealous. You get it? Hmm? You believe that this partner is jealous, and in your brain you really believe it, my friend. The delusion of jealous. Hmm? Persecutory, belief of being mistreated, spied on, or plotted against. They are plotting against killing me. Hmm? They are plotting against killing me. Imagine. Somatic, belief of having a physical defect or medical condition. You visit doctors, they tell you you are okay, but you believe that you have a medical defect, and it is, you believe it, and you cannot take it away from your brain. You believe that, for me, these people are lying to me. Hmm? I have this problem, and I cannot believe that what these people are telling me is not is okay. You see, and then we have mixed one, which is more than one of the above with no single theme. Mixed, somatic comes in, jealousy comes in. So when you are a young person and you are you want to get a partner, uh, if this partner is all over you and calling you every time, and often thinking that you are not okay, you are having some other partners out there. When you are with your people, your friends, having fun, this partner comes, you just know your partner is suffering from delusions, disorder, which is a psych problem. Then there is unspecified delusions that, that is not clear, fit any subtype. It doesn't fit any subtype. Now, what are the causes of what are the causes? We have biological, we have psychosocial stress, we have personality traits, we have history, family history, and age factor, middle age. You see, middle age mostly lie between uh, psychosocial stress, social isolation, migratory, sensory deficit, hearing, and jealousy. Jealousy. Jealousy comes in. Grandiose, believe inflated with power. You see, those that believe, this one come midlife crisis. Those that are older a bit. Somatic, believe that has a medical condition, it might come at everyone. You see, every stage in life. And then we have clinical features, core symptoms, persistent fail force, believe not to share by others. You get it? Insight. Typical poor patient convicted the belief is real. And then we have mood and affect. Mood and affect. Mood and affect. You believe that mood and affect is happening. What is happening here is sorry people, mood and affect. You see, these are psychotic behaviors. Now you know, psychotic is not to those people that are just removing their clothes in and walking around saying that we are psychotic. Many people need help, and one of the key issues when it comes to help, you have seen insights, mood and affect, hallucinations. You see, these are things that we should look at. But I repeat, the subtypes of delusion psychosis: aromatic, you believe that someone loves you, and that person you've never met, or this person does not know even have feelings for you, but always when you need people, you tell these people that you are in love with that person. And then we have grandiose, believe that you once had money, power, identity, and knowledge. You are so knowledgeable, you can talk all the English and all the science, you can quote all the scientific principles. And when you look at that person, this person is is a mad person or psych person. This is what we call grandiose. And then jealousy, a partner who always believes the other partner is unfaithful. Every time, every time. So, man, when you call someone psychotic, please, it's better to look at yourself first and see if you lie on these things that I'm talking about. Persecutory, believe that someone is always spying on you. Have you ever believed that someone is spying on you or looking at what you are doing? Somatic, believe that having a typical defect medical. Some people can believe that they have a medical, and you will never convince them. When you talk to them, they'll tell you, I have cancer. have never been treated. Psychosis, psychotic problems. You see, mixed is when you have this jealousy, persecutory, romantic, and unspecified delusions that don't clearly fit any specific type. You get it? Now, we go on causes. Causes, we have said, a person who is psychotic with delusions will be having biological problems like having dopamine dysfunctions in the brain, psychological stress, social isolation, migratory sensory deficit, e.g. hearing, migratory psychosocial stress. And then we have personality traits, paranoid, schizoid, or narcissistic tendencies. Family history. Family history of schizophrenia may be a very big hallmark when it comes to diagnosing a person. So you may look at the family. Do they have a history of these issues? Hmm? Paranoid personality and disorder. Age, common in middle-aged or adult. Middle-aged or adult. So we have talked about the clinical features of like hallucination, speech and behavior, organized and logical. You see, now when you meet this person, they are not having disorganized speech because disorganized speech mostly lies on the features of psychosis. But this is mood problem. They are so eloquent. They are having organized and logical speech. I mean, when we talk about logic, my friend, I will come and talk about a whole topic on logic. Unlike schizophrenia. Yes, someone will tell you, let me tell you, my friend. You see, when I met Donald Trump, Donald Trump was so nice. He was so romantic. We have always been on, and this person lives in Africa, has never had a passport, but he has met Donald Trump in her head. You get it? Very organized. Or this person may tell you, you know what? These people that you see out here, they are always planning on my downfall. Wherever I go, these people are fighting me. Yeah? These people, they are, I don't know what they want. Yesterday, I thought someone followed me up to my home. When I looked back, there was a spear. And when you think about it well, the time relations are not adding up. You see, this is a very organized person delivering a very organized line or speech to you, but the time context, and the way this person is talking can convince you that this is true. And then there is insight. Typically poor. Patient is confused, they believe it's real. Even if you try to tell this person, my friend, you've never had a passport. You see, Donald Trump doesn't know you. This person will tell you, oh, you go away, my friend. You don't know. I'm the one who was with that person. You see, insight, it's very poor. Hmm? The core symptom here is always persistent and fixed false belief not to be shared by others. You've met these people. I know one or two people have you've met this with these problems. And then hallucinations, absent or mild. You may not at times you may find a person is having absent hallucinations. Quickly, if you meet these people, one, they go to hospital, let them do the urine drug test. Maybe they are using marijuana a lot that is making them psych and having this delusion. You may do organ screening like electrolyte balance, thyroid tests. We have talked about how these organs may come in to to show this person to create this person the person he is now. The damage to end organ like thyroid, liver, and the kidneys. And sometimes you may put some tests for screening dementia and cognitive. The doctors know. The drugs, we will not talk about them. We'll talk about them tomorrow on management. Now, we have talked about delusional disorder and a psychosis. Now, the next one we are going to talk about is substance-induced psychosis. This one, I'll go to it so faster because everyone knows how a substance can induce psychosis. You get it? Everyone knows how a substance may induce psychosis. Hmm? Now, have you ever come through a person that has taken alcohol and is very fine? Eh? Out of the world. Different from the person you usually know. Hmm? Substance-induced psychotic disorder is a psychic disorder caused directly by drug intoxication, withdrawal or side effects leading to hallucination, delusions, and not better explained by psychotic disorders. You see, it is a substance that is bringing in these psychotic disorders. And I will not go deep into it because I've talked about how these drugs can do this. There are, let me call four neurotransmitters in the brain: serotonin for cognitive function, thinking, and doing; dopamine, the second one, that helps you to know how to bring in pleasure, things that you do for pleasure; and then the glutamate. We have talked about glutamate, how it is a co-transmitter. And then there is neuroleptin. So when you take a substance, it interferes with these three, these four neurotransmitters. When it interferes with them, if it goes down and affects reuptake to mesolimbic pathways, my friend, you start being psychotic. Marijuana is one of them. When you smoke marijuana, you start going down. You see, we should look at presence of delusions and hallucinations. Evidence. Go to the lab, let the doctor take the blood of this person to screen if this person has a toxic substance in the blood. Eh? The disturbance is not better explained by a primary psychotic disorder. There is no disorder that is primary that is explaining that this person in the family, maybe they have a problem, because there are some families you'll find that the family has a problem in the brain to release dopamine, or the family has a problem when it comes to release serotonin. You see, that is a problem genetically. But when you look at a person, they don't have that in their family. But this person has a positive test of marijuana, cocaine, alcohol. You know this is substance induced. Hmm? And you check and then you see the disturbance is not better explained by psychotic disorder, or does not occur during a delirium when recuperating. You see, and then there is a when you take the alcohol or the drugs that we are saying, you you are bad. Hmm? Like, let me talk about these substances. The substances may be cannabis, marijuana, cannabis, sativa, indica. All those are marijuanas. There is no difference. They cause the same thing. They cause hallucinations. And you see, when you start hallucinating, this is a positive sign of psychosis, paranoia, and delusion. So, marijuana cannot kill you, but it will make you be psych. You'll be mad person. The more you take, you don't tell me that I'm taking marijuana because I'm meditating. You are in your world. It has taken you out of the world and you are in hallucination. That's why the people that take marijuana, they will really try to convince you that there are some things they are doing that it's very important. They are always busy. They are always focused on funny things or things that are not related to the normal social life. Hmm? You be with one person who you've met a person who uses this. He's so focused when doing some things. But when you look at the things these people are doing, not connected to social environment, my friend. Cannabis, sativa, indica, all those, I don't know where, from Ethiopia or America or Amsterdam, it is cannabis. There is no difference. Cocaine, tactile hallucinations. Cocaine bags, because it brings it stops the reuptake of dopamine in your brain, and then dopamine piles up in the brain, and then you start to hallucinate. Paranoid delusions. You hallucinate, my friend. You start feeling you are the president. You are the director of where you are. You start giving instructions. Yes. Hmm? The dopamine in your brain is not being reuptaken. It is just rising, rising, and the dopamine level is rising. So it's showing you give instructions, and you're giving them in your own world because at that time you feel you are everything. Too bad. And then we have amphetamines. These are drugs that we give in hospital. But you see, when they are really misused or given badly, they start giving you visual auditory hallucination. You see, you start talking on what you are seeing. Grandiose or persecutory disorder, phenylcetidine, PCP, phenylcyclidine. These are drugs that gives hallucinations, vivid hallucinations. You see, prescription drugs that may make you be psychotic, like steroids, may cause psychosis and depression. Prednisolone. People that use prednisolone a lot and then your mood disturbed, you get to depression because of psychosis. Prednisone. And dopamine drugs used in Parkinson's, like levodopa. You take a lot of levodopa and then you have a lot of dopamine in your brain, because it crosses the brain barrier to the brain. You start having positive psychosis because of that. You get it? Anticholinergics like confusion, hallucinations in elderly, stimulants, methylphenidates. Those ones are overdose are not good. Antidepressants rare, but you see they cause at times. Very important when it comes to whatever that we are talking about, psychic disorder. Now we will talk about management tomorrow, and we will go step by step on how. Now we go to psychotic disorder due to another medical condition. A medical condition that may cause you to have a psychic disorder. You see, you may be sick and then it interferes with your brain. Hmm? And we have said the hallmark of psychosis is three neurotransmitters: dopamine, serotonin, and glutamate in your brain. So you see, the psychotic disorder due to another medical condition is characterized by hallucination or delusions directed by general illnesses, a prominent delusion, evident psychosis. You see, these are temporal lobe epilepsy. Epilepsy may cause because it is interfering. Parkinson's, we have talked about. These are direct things. Parkinson's, you are taking levodopa and it is increasing dopa in your brain. Huntington's disease, stroke in the brain, multiple sclerosis, inflammation may affect perception because it is affecting the brain and you are getting inflammation. Traumatic brain injuries. And then there is metabolic. When you talk about metabolic, we are talking about some things that are released, that are balanced in your body. Hyperthyroidism, eh? Hypothyroidism. Those are things other medical condition it may tamper with your serotonin or the neurotransmitters. Hypoglycemia, I've talked about all this. Hepatic and renal failures, renal, the kidney, creatinine going up, all those. The vitamin B deficiency, delirium and hallucinations. You get it? Hmm? Infectious diseases. There are some diseases that may cause these problems, like neurosyphilis, delusions, syphilis that goes up to your brain. So be careful when you are having sex randomly without condoms and not protecting yourself, the partner because you just think that person has no HIV. Very bad. HIV and AIDS may do this. Herpes encephalitis, limbic damage, severe psychosis. Herpes, the virus that causes herpes goes to your brain and then it causes encephalitis. You start hallucinating. Sepsis, you get it. Symptoms may be delusions, hallucinations. Check on the onset, which is gradual, acute or gradual, once or you see, insight, frequently impaired. Cause may improve in underlying, but you see, the pathophysiology, medical illness may cause brain to how it happens. When I'm talking about pathophysiology, I'm talking about how it happens. The medical illness may cause brain inflammation, structural lesions, metabolic imbalance or neurotransmitter dysregulation. You've seen how it comes about. What you are suffering may cause brain to swell, structural problems like sometimes a brain somewhere has an infarct, a piece of tissue is dead, metabolic imbalance like sugars, electrolytes, you see, or neurotransmitters like dopamine and serotonin and glutamate and adrenaline or norepinephrine, they get an imbalance. I've always talked about that. Disruption of dopaminergic glutamate and cholinergic system may trigger psychotic features. You see that? There seems, these ones I will not talk because not of, all of us are doctors. Or the steps in diagnosis, talk about tomorrow. Management, treat underlying cause. That's the first one. We'll talk about it. So we have talked too much today about psychosis. If you have a question, always put that question in my email. You always have my email somewhere in the video. So you guys have a good day. This topic will continue tomorrow, the same time. If you have any question, please put them so that tomorrow we know how to treat psychosis. We know how to help people that are psych, those that you call mad, to come to be better in the society and know how to help to be prosperous and help the society. Be blessed. Have a good day.